acute fungal rhinosinusitis. Fungal diseases are getting more and more common. Why? Because people are living longer, more cases of immunocompromised status, jata antibiotic, okay, even the coax and all, everybody is prescribing antibiotics, the rise of allergy throughout the population, and more diagnosis is now possible because of the imaging modality and microbiological advancement. Okay. Allergic fungal rhinosinusitis, the acute one, is very, very dangerous. It behaves like sometimes like malignancy. There is a tendency to breach all the nearby structures very early without giving much symptom earlier. Okay. Any fungal disease এর একটা characteristic হচ্ছে the symptoms will be less initially. Okay. Once it is getting fulminant, the symptoms are very aggressive, and mostly you have to depend with your clinical acumen to diagnose it early with history. So the most important thing is it is invasive in nature. So at a patient, you cannot miss a patient with the history of allergic fungal rhinosinusitis, acute fungal rhinosinusitis. Okay. Immunocompromised individuals, again, who are the immunocompromised individuals? Kara kara? Always HIV first. HIV is a virus, boss. Diabetes when it is uncontrolled, okay? And HIV when it is advanced stages, AIDS and all, right? Getting HIV is not a disease itself, it's just a virus. It gives rise to lot of spectrum of diseases, right? One of those is, in HIV cases, you can see a lot of fungal things in your body, right? In your lung, in your sinus, in your GIT, in your brain as well, okay? And it is rapid onset. Once it sets into motion, it is very rapidly progressive. What does it give? What are the pathogens? Most commonly Aspergillus in our country and this mucorrhizae. Chemotherapy people, right? Patients are getting chemotherapy, more prone to fungal problems. Uncontrolled diabetes is the topmost cause in our country, right? We are the country of diabetes and tuberculosis and all these things. What does it call? Worms, right? We are the countries. Chemotherapy, why it is getting more common nowadays? Because more malignancies are getting diagnosed and patients are getting treated. So chemotherapy induced immunocompromised status is also a cause, and organ transplantation. It's very common, especially in this Maharashtra, Gujarat, all this area. Renal transplant every day. In each hospital, 4 or 5 renal transplant every day is happening. Okay. So we are getting renal transplant, we are getting liver transplant, we are getting what? Lung transplant, we are getting heart transplant, right? We are getting hand transplant, we are getting bone marrow transplant. All these patients are being put into steroids, right? Why? So that our own immunity does not reject that organ. Okay? So if you put those patients on steroids, what will happen? The immunocompromised status will start, right? And those patients are very, they can have this fungal rhinosinusitis. It is having a rapid spread through vascular invasion as well as local infiltration, right? So, rokto diye this can spread. And very early meningitis, epidural abscess, subdural abscess, other forms of brain abscess, cerebellar abscess, temporal abscess, all these things will start. Orbital spread, 5 stages. It's a grading actually. Mostly in postgraduate thing, but you can remember. First it starts with periorbital edema. Then there will be orbital cellulitis. Then subperiosteal abscess. When this subperiosteum, periosteum is breached, it will lead to orbital abscess. And when there is cavernous sinus, ultimately cavernous sinus thrombosis. Okay, these are the stages of orbital spread of any rhinosinusitis related any disease. Okay, acute viral, bacterial, fungal. These are the stages. আমি আগের দিন বলেছিলাম cavernous sinus thrombosis is a typical presentation, right? A patient with ptosis, with proptosis, with high grade fever. The single most diagnosis should be first, that should come first in your mind. It should be cavernous sinus thrombosis, right? What is proptosis? Proptosis কাকে বলে? I will show you. So these patients are present severely ill, fever of unknown origin, you cannot get any origin, nasal discharge, headache, and mental status changes ultimately. So patients having fever, ophthalmoplegia, ptosis, proptosis, chemosis, ultimately blindness, meningitis, all these things, you will suspect that a focus can be from your paranasal sinus, right? Okay. So what are the imagings you will do? CT scan, first investigation, CT scan with contrast, right? তাই তো CT scan নিয়ে idea আছে? It's an extended form of X-ray actually in 3 dimension, right? Okay, X-ray একটা single view, single cut, but CT scan give you multi-dimensional views, right? In different cuts. We can select the cuts, 1 millimeter gap এ করব না 2 millimeter না 5 millimeter. Okay, so we will get a better view of that area, 3-dimensional view. But it has a problem that it has a high radiation, right? And when to give contrast? Whenever we suspect there is a tumor or cancer, whatever, and infection, right? So we will go for a contrast, right? And if there is any involvement of the brain, if you suspect in CT that the disease actually breaching your boundaries, bony boundaries, and getting into your brain, then we will go for an MRI, right? MRI gives a better soft tissue view, right? CT scan is for bony details, MRI is for soft tissue details. ঠিক আছে? This is the T1 imaging, এত ডিটেইলের দরকার নেই. Okay, it's intermediate to low signal you can get, and it is with gadolinium contrast. Okay, T1 with gadolinium contrast, and it is having peripheral enhancement at the initial period. Okay, and in T2, T1 is for mostly for anatomy, right? In T1 we can get details of anatomy, কোথায় কোথায় ডিজিজটা রয়েছে. But if you really want to know what is the pathology, then T2 is the sequence. Okay, জানা আছে এগুলো? জানা নেই. So আমি একদিন radiology class নেব, then you will get into those things. Okay, then we will go for an endoscopic evaluation, right? নিজের চোখে দেখার থেকে ভালো কি হতে পারে, তাই না? ইমেজিং ইজ যেটা আমি চোখে দেখতে পাচ্ছি না, টু গেট দ্যাট এরিয়া, রাইট? অনেক কষ্ট মষ্ট করে এই সিকোয়েন্স ওই সিকোয়েন্স এত বছর পড়াশোনা করে তারপরে উই গেট অ্যান আইডিয়া. বাট হোয়াট ইফ উই গেট আ ডাইরেক্ট ভিউ endoscopically, right? It's possible. So if we get a patient with this fungal disease we are suspecting with our endoscopic examination, first thing we will do, we will get a biopsy, right? We will take some mass from that area and send those for what? Fungal kina jante ki examination korbo? Which laboratory test we will do? We will go for fungal stain and fungal culture, right? With fungal stain we will get an immediate idea, with culture we get the specific selective organism we can get, right? So histopathology, এটাও আমি একটা ক্লাস নেব আলাদা করে. So hyphal invasion of the mucosa, submucosa and blood vessels, if both three are present, right, then mostly it is a fungal disease, right? So how will you treat that? Antifungal, right? Not any antifungal. Any antifungal will not work. What are the antifungals? Name some antifungals. Ketoconazole, mostly as a shampoo it is used and local applications, okay. And we have some systemic thing. Not any regular antifungal will work here, right? It's a very aggressive disease. We have to fight it aggressively, right? So best thing is Amphotericin B. And Amphotericin B is a very hazardous antifungal, okay. It has lots of side effects, right? What are the common side effects? What is the most common side effect of Amphotericin B? It kills your kidney, right? Amphotericin B dudin dile kidney will damage. The kidney will shut down. So that's why we have pharmacokinetic wise we have developed liposomal variant, right? So that the damage is less but still there. And we will debride the involved structure. Everybody has gone through the corona episode, I think, COVID. You have heard about some disease called mucormycosis black fungus, right? Patient er nake kane hocchilo, chok fok sob bad diye dite hocchilo. This is the thing, mucormycosis. Extensive debridement is needed, okay. So you will be very, very ruthless in operating. If you suspect any fungus in your eye, you will cut it out. In your nose, in your cheek, in your skin, in your brain, anywhere, you will cut it out, right? And get an aggressive antifungal therapy. So it's a radical debridement of the necrotic tissue, and there is a separate specialty, subspecialty in our discipline, skull-based specialty, which deals with our skull-based lesions. Sometimes neurosurgeons, sometimes ENT surgeons, both are team up. So we call them, right? Who has the masters of that area, right? So Amphotericin B, the dose, you know, and after that we will put on itraconazole, right? Itraconazole 400 milligram per day is the usual dose for the maintenance. How many days we have to give itraconazole? It depends, but mostly we give it for 1 month, right? So these are the postgraduate things. Whatever I have told you, Amphotericin B, lots of side effects. How to give it? We have a specific protocol. And how will you follow up those patients? Those patients has to be closely followed up, closely. That means anything happens, come to us. Anything happens, come to us. Okay, little bit of blood discharge, come to us. Blindness or difficulty in vision, come to us. Headache, come to us, right? So you will be very, very vigilant. And despite of everything, 50% patient dies. Do you know any other disease that has 50% mortality in 4-5 days? I am not talking about chronic thing. The patient is having ischemic heart disease, had an AMI and death. This patient was well, it's all okay. In 4-5 days, patient dies with the infection. This is one of those high morbid, high mortality disease, right? So these are the few slides. Now this is the thing that will come to your exam. You will given a patient of this nasal polyp, right? So these are the things examiners are very interested in asking you, because it is in your curriculum. You cannot miss a nasal polyp, right? And after that you have to diagnose whether it is an antrochoanal polyp or ethmoidal polyp. Okay. So this is an old classification, but mostly we follow it even today. Nasal polyps are mostly of two types, antrochoanal polyp and ethmoidal polyps. I have written this bilateral ethmoidal polyps because to put it in your brain that ethmoidal polyps are mostly bilateral, right? So bilateral ethmoidal polyp, just make it a habit, so that you cannot miss. If you see unilateral polyp in one side of your nose, you will suspect antrochoanal polyp, right? If you see both sides of our nose are having polyps, you can suspect ethmoidal polyps. Okay. Antrochoanal means, what is antro and what is choana? Choana means posterior part of your nose nasal cavity, the nasopharynx and all, right? The posterior opening into the nasopharynx of your nasal cavity is choana, right? And antro means maxillary antrum, right? Maxillary antrum, maxillary sinus, right? The cavity within the maxillary sinus, it's known as maxillary antrum. So this polyp starts with your maxillary antrum and goes towards choana. তাই তো, মানে পেছনের দিকে যাচ্ছে। Why? সামনের দিকে বেরিয়ে আসছে না কেন? Because of the location of the maxillary sinus opening, right? It's inferiorly and posteriorly. So gravity wise it will go posteriorly, right? And ethmoidal polyps are mostly comes anteriorly, right? So this is your choana, nasopharynx area. Okay. Sometimes you can see the polyp is propping down into your oral cavity. Okay. মুখ খুললে পলিপটা দেখতে পাচ্ছ, if it is too big. Right? It's a kind of, what kind of polyp is? It is antrochoanal. So this is the middle turbinate. This is your maxillary sinus opening. The polyp is coming out of the maxillary antrum and goes towards antrum, choana. So it is known as antrochoanal polyp. Okay. So how will you diagnose? This probe test, okay, it will be asked in exam, but we generally do not do it. Sometimes we do. What do you mean by probe test? We will put a probe inside your nose around your polyp and we will see where is the attachment, likely attachment. Okay, pretty gross test. Be careful, don't do it, okay, without any supervision. If it is a mass or something, it will start bleeding. Okay. So probe test will give you an arbitrary idea. Okay. Now these questions will be asked in your MCQ. Okay. There are certain diseases in your body, some syndromic, some non-syndromic, where the nasal polyps are very frequent and recurrent. Okay. Even you treat the most. You treat everything, you did everything, you did a very good surgery, you followed up the patient, you give a good allergy treatment, everything, still those patients will recur. One of those is cystic fibrosis. Sweat test, you know, cystic fibrosis genetic, janis to? What is cystic fibrosis? Autosomal dominant or autosomal recessive? Huh? Everybody is silent. Cystic fibrosis পড়ে আসবে পরের দিন, okay? কোন channel, chloride channel, everything, okay? Next is primary ciliary dyskinesia. Third is Kartagener syndrome. Kartagener syndrome comes with infertility as well, male type of infertility, okay? Because the sperm lost the mobility, okay? So those patients coming with nasal polyp and infertility. So your suspicion will be, can it be a Kartagener syndrome? Okay. Another thing, aspirin. Patients with aspirin, okay, there is a triad, Samter's triad. এটাও পড়ে আসবে পরের দিন, I will ask. Okay, patients with aspirin have more chances of developing nasal polyps, right? And these are the syndromes: Church-Strauss syndrome, Kartagener syndrome, Young syndrome, Gardner syndrome. These are the syndrome where you can have more frequent nasal polyps. So I was talking about this classification. It's known as Chandler's classification. Any acute rhinosinusitis, fungal, viral, whatever, it can have these grades of complications. Starts with preseptal to orbital to subperiosteal, orbital abscess, and ultimately cavernous sinus. Right? So this is your eye. This is a type 1. That means preseptal. Type 2 means orbital. Type 3 means there is an abscess in the subperiosteum, but the periosteum is not breached yet, right? After that, it gets breached and it start becoming the orbital abscess. Ultimately, it goes into the cavernous sinus, right? This is one of the case. How will you manage it? It will not be asked your curriculum. Anyway, like all the abscesses, you have to take a swab, you have to get a culture, you have to start antibiotic. If it is not resolving, we'll go for what? Surgery. We'll drain the abscess, right? And what is the approach? We'll go through nose. Through nose, we will go to orbit, right? And we will drain the abscess. Where you will go for urgent CT scan. ঠিক আছে? কোন পেশেন্টদের আমরা আর্জেন্ট সিটি স্ক্যান করব when I suspect some orbital complications. একটা পেশেন্ট এসছে তোর কাছে চোখ টোক ফুলে একদম, তাই তো? These are the cases where you will go for urgent CT scan. All pediatric cases, because within hours they can develop meningitis, right? We have to intervene very fast. If there is any abscess, severe pain, fever, right? If the patient starts developing neurological symptoms like convulsions, like altered sensorium, like severe headache, okay? And cavernous sinus thrombosis suspicions. Just tell me what are the features of cavernous sinus thrombosis? Ptosis with proptosis, right? This will not be asked. This is one of the thing, you know, this is lateral canthus, medial canthus. Sometimes the pressure within the orbit builds up so much after these complications that we need to release the pressure, okay? For that, lateral canthotomy. Just cut down the lateral canthus and we drain, we give a space to lower down the orbital intraocular pressure, right? So that blindness does not develop. We'll get some time for specific intervention. সবাই বুঝতে পারছো? People are not understanding. When they will get a patient like this, then you will understand. This is the class where you have been last taught in your life, and you can literally save a patient if you just give some orientation or get some attention, okay? Now, allergic rhinitis. I think these are the kinds of patient we can see every day, everywhere. হাঁচি করে যাচ্ছে, সকালে হলো 10 বার 12 বার হাঁচি করে যাচ্ছে, নাক দিয়ে জল ঝরছে. These patients are getting more in number because of the increased industrialization, pollution, everything. We are getting more and more cases of allergic rhinitis. It's a type 1 hypersensitivity reaction, right? IG mediated. What are the symptoms? Patients, excessive sneezing, itching, নাক দিয়ে জল পড়ছে, and নাকে নিঃশ্বাস পাচ্ছি না ভালো করে, তাই তো? You will suspect there is some allergies going on, okay? How will you treat and how will you investigate? Mostly clinical investigation, but based on the symptomatology, we can get a differential count to see whether there is rise in eosinophil or not, okay? We'll get a nasal smear and get for specific allergens. We can get some skin prick test, okay? And radioallergoservant test, RAST, right? How do you treat? Antihistaminic, cetirizine, right? Initial drug. We'll get sympathomimetic drugs. In some cases, we can give corticosteroids in severe cases, and chromoglycate like montelukast, anticholinergics, okay? Leukotriene receptor antagonists, leukotriene receptor antagonists are montelukast, and anti-IgE immunotherapies as well, okay? That's what I was telling. Samter's Triad, okay? You can just remember it. Nasal polyp, asthma, aspirin sensitivity. This is the triad. Patient coming with nasal polyp, with bronchial asthma, with history of aspirin intake. This is the triad, Samter's Triad. It will be asked definitely in your exam. MCQ te ashbei, okay? So, allergic rhinitis patients having a history of bronchial asthma, most of the cases, because it is a same airway disease, okay? So, if you treat the allergic rhinitis very well, asthma exacerbation will also get down, getting less severe, less frequent. Patients can have middle ear effusion as well, and obstructive sleep apnea. It's a very important thing. It is also rising, okay? ঘুমের মধ্যে হঠাৎ করে দম বন্ধ হয়ে মৃত্যু. This is obstructive sleep apnea, okay? That means your airway is not getting enough passage for airflow, right? It might be your nose, it might be your oral cavity, oropharynx, nasopharynx, larynx, anywhere, okay? So sleep apnea এর উপর আমি পরে একদিন যদি টাইম পাই I will get to you. It's a very interesting topic and everybody should know. Polyps tumor আগের দিন বলেছিলাম, it's osteomyelitis of the frontal bone as a complication of rhinosinusitis, and mucocele is also a complication. How will you differentiate between those? It's a mucocele is a complication of chronic infection mostly, okay? So patient will have a longer course of disease, and you will get the differentiation with your imaging, CT scan and MRI. Now this is also important, granulomatous disease of the nose, okay? One of those is important is Wegener's granulomatosis, medicine পড়ানো হবে, pediatrics পড়ানো হবে, and ENT তেও পড়ানো হবে, and Church-Strauss syndrome. Few features are common in both the cases, vasculitis, sinusitis and dyspnea, bronchial asthma, okay? And in Wegener's, renal failure is more, epistaxis is more, and those patients are C-ANCA positive, okay? Church-Strauss syndrome, asthma is more, eosinophilia is more, and P-ANCA positive, right? Patients with having this spectrum, having epistaxis, with features of vasculitis, renal failure, okay, RPGN type of symptom, okay, sinusitis, recurrent, you will get a C-ANCA. If the C-ANCA is positive, the diagnosis is mostly Wegener's granulomatosis, okay. So granulomatous diseases are very common in our nose, okay. See, these you will learn in your medicine. These are all the in your rheumatology, okay. Giant cell arteritis, Behçet syndrome, relapsing polychondritis, all the features and all. Everybody has some manifestation in your nose and paranasal sinus, okay. So you have to learn. Osler-Rendu-Weber disease. This is also a question for your MCQ. It's autosomal dominant, mostly telangiectasia on which branches on pressure. Patient mostly comes with bleeding, okay. Bleeding per rectum, hematemesis হচ্ছে, epistaxis হচ্ছে. These are the you can suspect. Can it be a Osler-Rendu-Weber disease? Specifically, if there is a positive family history, right? Just know the name. Crest syndrome is associated with this thing, and obviously some bleeding disorder, von Willebrand disease is a differential diagnosis. Patient having multiple orifice bleeding, okay. First you have to think if there is any bleeding disorder or not, okay. Next, these things. Osteoma, this is a frontal osteoma, this is a frontal sinus, right? Okay, this is a frontal osteoma. How do you treat? Excise it. How do you excise? Via your nose or open approach, anything, okay. Obstructive sleep apnea, I told you I will get to you later on. Just know this name, polysomnography. This is an investigation for your obstructive sleep apnea to know the severity of the disease, okay. So patient, it starts with naak daka. Everybody knows naak daka, snoring. Snoring is a initial stage, one of the initial stages of obstructive sleep apnea, okay. So if a patient comes with severe snoring, সারাদিন ঘুম ঘুম ভাব, কোনো কিছুতে এনার্জি নেই, স্যার ডাক্তারবাবু কিচ্ছু করতে ভালো লাগে না, সারাদিন ঘুমাতে ইচ্ছা করে, এখানে টেবিলে বসে বসে শুয়ে পড়ছে, ঘুমিয়ে পড়ছে, ask whether the patient is having, just ask yourself, okay, this patient can have obstructive sleep apnea, right? Patient ঘুমাচ্ছে ঠিকই কিন্তু অ্যাকচুয়ালি ঘুমোতে পারছে না, because his brain is keeping him always awake so that the respiratory passages does not collapse in sleep, right? যদি respiratory passage collapse করে যায় স্লিপের মধ্যে তাহলে কি হবে? ডেথ, তাই তো? So these patients develop early diabetes, early hypertension, early ischemic heart disease, all these things. So wide spectrum of disease. If you are interested, I will get back to you on later date. How will you treat? Just get this idea at back of your mind. Weight loss, alcohol intake sleep positioning, CPAP therapy, oral appliances sometimes, and we have lots of surgeries, right? Now, coming into CSF rhinorrhea, okay? CSF is cerebrospinal fluid, right? So CSF is leaking through your nose. That means there is some defect, right? Durate kichu defect royeche. So it can be because of trauma, because of some acute inflammations, some tumors, cancers, congenital lesions like meningocele, meningoencephalocele, glioma, any skull-based defect, and most commonly, surprisingly, it's idiopathic. Okay, mostly middle-aged female with some obesity, kind of. Suddenly, she is telling you that I am having some nasal discharge, water discharge. Okay, so nasal discharge mane, it can be because of allergic rhinitis as well. But unilateral discharge, ekdik diye porche, top kore jol porche, clear fluid, clear water. You should suspect the CSF might be leaking. So what will happen if CSF gets leaked? It's an open door to brain, right? So you can, the patient ultimately will have meningitis, right? Infection will go to her brain. So this is if you get a case of CSF rhinorrhea or in any table, it is you have a discussion, then these basic questions will be asked. Okay, what is the total volume? How much CSF is getting secreted? What is the pathway? কোথা থেকে কোথায় যায় CSF? পারবে সবাই? বলো। CSF কোথা থেকে প্রোডাকশন হয়? থার্ড ভেন্ট্রিকল। আরে কি থেকে তৈরি হয়? এটাও জানো না। আলটিমেটলি কোথা দিয়ে কোথায় যায়? প্রথমে থার্ড ভেন্ট্রিকলে চলে যাবে। ল্যাটারাল ভেন্ট্রিকল গুলো কি করবে? কোরয়েড প্লেক্সাস, রাইট। তারপর খুব খারাপ অবস্থা। Okay, so these are the investigations that you have to get a case of suspected CSF rhinorrhea. Beta transferrin and beta trace proteins, these are the questions asked in MCQ, right? This is a specific test, okay, as well as you get a CT and MRI, plus minus what is happening? What is happening? I don't know. Something is wrong. Okay, CT and MRI. This is a flow chart. So get to this question. 45-year-old overweight women, persistent clear unilateral nasal discharge. CSF rhinorrhea. Okay, got the idea? So differential diagnosis, allergic rhinitis, vasomotor rhinitis, gastrectomy rhinitis, all these things. What is the treatment recommended of allergic rhinitis? We'll classify as per the severity, right? So less severe patients will get less treatment, more severe more treatment. Start with oral H1 blocker. These are first generation these anti-allergic tablets, right? And decongestants. Moderate symptomatology, we can give intranasal corticosteroid. This is the mainstay of treatment, right? And in severe, we can give some oral corticosteroid, as well as we'll start ipratropium, and we will increase the corticosteroid dose, intracorticosteroid dose, and we will combine with agilestin like drugs, right? Get to the question. Endoscopic intranasal operative view, right? So endoscopic view of your nasal cavity. What do you see? Patient is having what? A polyp is there, right? Suppose the patient is having both nostril having some polyps. Okay. So what is your diagnosis? Ethmoidal polyposis. What are the two presenting symptoms? কি কি সিমটম হবে নাকের মধ্যে পলিপ থাকলে? নেজাল ব্লকেজ, নেজাল অবস্ট্রাকশন, রাইট। আর ব্লকেজ থাকলে কি হবে? লস অফ নো স্মেল, অলফ্যাক্টরি প্রবলেমস, রাইট। আর কি হতে পারে? ব্লিডিং হতে পারে, ডিসচার্জ হতে পারে তো। টু মেডিকেল ট্রিটমেন্ট। ethmoidal polyps are mostly because of allergies, right? Antrochoanal polyp is not because of, mostly not because of allergies. So ethmoidal polyps যদি অ্যালার্জির জন্য হয়, there is a this thing what we called how to differentiate between AC polyp and ethmoidal polyp. It's written in your book, right? But individually with discussion বললে পরে you will remember more. Okay? So if I give you the idea that these patients are mostly because of allergy, so what two medical treatments you will give? Allergy treatment debi to? What are the name two allergy treatments? Glyphosate, just don't give, classify the drugs first. Antihistamines. Okay, anything else? You can give some steroids as well. Intranasal steroids you can give, right? And what surgical treatment you will give? It's not surgical excision, it's, yes, it's surgical excision, but we do it endoscopically, right? And we call it endoscopic sinus surgery, right? Older days it was called functional endoscopic sinus surgery, right? FES, functional endoscopic sinus surgery. Nowadays we call it just endoscopic sinus surgery. Why functional? Because we try to preserve the function of the sinus, right? So we don't remove all the mucosa and everything. We just remove the polyp and unhealthy mucosa and keep the other healthy mucosa intact so that it can function properly, right? So in any nasal thing you will utter this word, endoscopic sinus surgery, right? Wheezy chest ashe patient reported a wheezy chest, that means patient is having bronchial asthma as well, right? Wheeze ache. So what I told that allergic rhinitis patients mostly have bronchial asthma as well, right? And complications of surgical removal of endoscopic sinus surgery. So you have to know what is the complication of FES, right? So we will get into that on our next class, right? It's a huge topic. So FES complications, just get a screenshot and just think yourself how these complications can happen, okay?